name of this session is Saviours in Anterior Segment Surgery. And the reason why we have labeled it as Saviours in Anterior Segment Surgery is because of the fact that there are certain scenarios in anterior segment surgeries like cataract, wherein you feel that these are troubled situations, wherein you would like to be saved. And myself and Professor Namrata Sharma and myself will be doing this, but unfortunately she is also stuck for some time. So I will start the session, and we will be mainly talking about three groups, and would like to have your input as well, because you all have been, most of you will be doing cataract, cornea and refractive surgeries. So we'll be dealing with three such sets of scenarios of cataract, cornea and refractive. And both of us will be handling different scenarios. So since Dr. Namrata is not here, she will be talking about posterior polar cataract and cataract surgery in eyes with corneal opacity. And in cataract, I'll be taking care of the subluxated cataract and another scenario. So let's first talk about subluxated cataract. Now, you all must have faced the scenario of subluxated cataract, wherein there is zonal deficiency. If there is a zonal deficiency, something like this, a zonal deficiency of 200, a zonal deficiency of 100 degrees like this, the basic idea is that we should, I'll just stop it here, and I'll say that in such cases, everything is important. A good visibility is important. Then viscoelastic is important. And in such cases, if we use chondroitin sulfate containing viscoelastic like Viscoat, I don't have any financial interest, but if we use Viscoat, then it also covers up in the area where there is zonular deficiency. And there is no sudden fluctuation in the anterior chamber. So that is very important. And then once you have injected viscoelastic and done the rhexis, it is better to support the area, the capsule in the area where there is zonular deficiency. So this is how we should do it. And the routine chopping technique should be done. The parameters should be on the lower side, so that there is not much of fluctuation. And as you can see here, the viscoelastic, the nucleus has been removed. And then again, whenever you remove the probe, I'll just halt here. Whenever you remove the probe, I'm sorry for that. Whenever we remove the probe, we inject viscoelastic from the side port so that there's no sudden chamber decompression, and that can also result in further zonular deficiency. Then we inject viscoelastic from the side port, and if you see that the zonular deficiency is about 90 to 100 degrees, in that case, endocapsular ring is sufficient for maintaining the capsular bag in position. That too, if it's a traumatic zonular deficiency, because it is not a progressive disease. So if it is because of trauma and you have a loss of nearly 90 to 100 degrees of zonules, in such a case, you can handle with just a routine endocapsular ring and complete the procedure. Now, if the zonular deficiency is more than that, if the zonular deficiency is something around, say, 160, 170 degrees, then in that case, it's better to fix the bag with a Sionese ring. So in this case, again, would like to do the same. Do a rhexis, support the capsule, either you can put the capsular hook, or if you don't have the capsular hook, you can even use iris hooks The idea is that you should go posteriorly, at the posterior limbus, so that you don't pull the bag. It should go slightly parallel, and that is how you can prevent damage to the capsule and to the capsular margin. And then with the help of a 9-0 proline suture, you can you can put the Sionis ring. The limb with the eyelet has to be above the anterior capsule, and the ring should be inside. So it should be like this. And then when once it is in position, you tighten the suture and pull it so that the eyelet goes into the periphery, and then you can put the IOL in the bag. Now, if the zonular deficiency is more than that, something like this, and that too a progressive zonulopathy, in such a case, it is extremely difficult because you can see it's almost gone. Maybe it's just there with the help of some zonules. So in such a scenario, it is better to remove the whole lens with the capsule and do an intrascleral haptic fixation of IOL. So earlier, long back, we used to do suture fixation. Then we did a study comparing suture fixation with intrascleral haptic fixation, and we found out that the pseudophagogenesis in intrascleral haptic fixation is much less. It is absolutely negligible. But with suture fixation, you fix at 2 points. So with the movement of eyeball, the lens also moves quite a lot. We did a UBM study and we found out. So in these cases, if it's a young individual, you can just do intralenticular lens aspiration. And so intralenticular lens aspiration means you create 2 openings, take the irrigation cannula through the opening into the lens and the aspiration cannula, stabilize the lens with the irrigation cannula, bring it towards the center and keep aspirating. And once you have done that, remove the bag and then create a pocket and a flap on both sides, exteriorize the 2 haptics and tuck the haptic into the pocket created adjacent to the flap, and then you can put glue onto the surface. And that is how it completes the procedure. Sometimes you get a case of a microspherophakia. There also you have variable degree of subluxation. It can be behind the iris. Sometimes it is so much and subluxated that it comes even anterior to the iris. So if it is anterior to the iris, then you can remove the whole lens and do a intrascleral haptic fixation of IOL the way I showed in the previous case. But if it is behind the iris and it is in position, in that scenario you can, like this, in such a case, using viscoat and by stabilizing the capsule, you can go ahead and complete the procedure. Most of these microspherophakia patients, they are young, and the surgery is done at a young age because they have very high myopia and astigmatism. So you have to do it at the young age. So you just aspirate the cortical fibers completely, and then once you have aspirated the cortical fibers, then you put intracapsular ring in the bag, and then you can place the IOL in the bag. Because in microspherophakia, most of the times you do get zonules on all sides, and the zonules are present, but they are quite lax, and that results in a spherical shape of the lens. So if you stretch it with the endocapsular ring, it stretches well and it stays well in position, and you can put the IOL in the bag. Dr. Namta will come and talk about cataract surgery in eyes with cornealopasty and disorders. I'll be talking about traumatic cataract with iridodialysis, and we'll be doing cataract surgery. We'll be showing cataract surgery with iris repair. Now, if you have a traumatic cataract wherein you have a partially absorbed cataract and a fibrotic membrane with this kind of a dialysis, iridodialysis, in such a case, it's better to repair the dialysis first because you have enough space. So you can repair the dialysis first and then do the membranectomy and put the IOL in the sulcus. Because if you do the membranectomy first, put the IOL in sulcus, then the eye becomes a little hypotenuse, because when you are doing membranectomy, you do some amount of anterior vitrectomy also. That is why it is better to repair the iris first. So in this particular case, as you can see here, there is synechia present in this part as in this part. And the iris has come like this. So what happens that there are folds that are created in the iris. So you not only have to release the synechia, but also have to stretch the iris so that these folds disappear. And then you have to fix the edge of the this dialyzed iris transclerally so that it remains in position. So this is how we create a groove at 1.5 millimeter position, and then synechia release is being done. And once we release the synechia, you stretch the iris a little bit, and then you just hold the edge of the iris, dock it into a 26 gauge needle, and exteriorize. Similarly, you do another such needle. You create a paracentesis and you go through the opposite side, and then you just hold the edge of the pupil. And sometimes when you are doing it, what happens that the iris gets pulled onto one side, so you have to stretch it to bring it towards the center. So as you can see here, it went onto one side, but it started coming again. And then in between, you have to stretch the iris as well. And then similarly, you keep putting the, as you can see here, I'm just stretching the iris, and as I stretch it, it comes well in the center. So you just have to titrate the tightness of the suture as well. And once this is done, you can see the configuration. The pupil is dilated, but the configuration of the pupillary margin is circular. It is not notched here. So that means that the iris has been appropriately pulled. It is not too much pulled. That is important. And then we do a membranectomy. And once we do a membranectomy, we can put a multi-piece IOL in the sulcus, and that will take care of it. But if this is the post-op picture, as you can see here, it's a reasonably circular pupil, and here there is complete repair of iododialysis has been done, and it's almost reasonably circular, not getting notched significantly to come to the edge of the IOL. But if you have a traumatic cataract which is swollen, in such a case you have to create space. So this cataract surgery has to be done first. So you release synechia here, and then you stain the capsule. Use high viscosity viscoelastic, but also with chondroitin sulfate so that the chamber remains stable. Now in this particular case, I can see that the pupil has dilated well, so I have not put any iris hooks. But if the pupil is not dilating well and it is coming into the center, in that case it's better to put the iris hooks. And then you put the endocapsular ring, place the IOL in position, and then repair the iododialysis. So this is how it is done. The iododialysis repair has been done, and you can see here that the pupil, again, in a dilated state, the margin, what is important that when you are doing the surgery, the pupil sometimes does not constrict that much. But if the area where you are repairing is getting notched, the margin is getting notched, pulled on one side, then it is not correct. This means that you are pulling the iris too much. But if the configuration is circular, this means that your pull onto the iris tissue is appropriate. Sometimes you get iris coloboma with cataract, something like this. So, if you have an iris coloboma with cataract, then you do cataract surgery, place the IOL in the bag, but what happens that in this area there will be aphakic zone, and in the central area there will be pseudophakic zone. So you have to repair the iris as well. So go ahead, complete the lens surgery, and in most of these cases where there is iris coloboma, there is some degree of zonular deficiency in this area. So it is always advisable to put endocapsular ring in these cases. So, but this dehiscence is not that much that you are not able to complete the procedure. So once you have removed the nucleus and removed the cortex, after that you can put the endocapsular ring. So inject high viscosity viscoelastic and then put the endocapsular ring in position. You just have to ensure that the endocapsular ring is in the bag, and there are some injectable endocapsular rings as well, and that can also be used, but that is a little costlier. But you can use the routine endocapsular ring, which are non-injectables also. And once you have placed the IOL in the bag, remove the viscoelastic from the front and from behind. Because once you have done the iris repair, you will not be able to remove the viscoelastic from behind the lens. So remove it from behind the lens nicely, then put some viscoelastic into the anterior chamber. Don't put too much, otherwise it will push the iris tissue. And then the first suture should be passed at the margin of the intended pupil. So this is the margin wherein you put the first suture. That is important. And then as you tie the first suture, this is a single pass fourth row technique by which the pupilloplasty is being done. And the first knot has been tied. So you can see that it is now a reasonably circular pupil. Now you have to cover this area which is open. So you put another suture in the periphery and see whether it is closing or not. And once you put the second suture and tie the knot, then you see if it is not completely closed, you may have to put the third suture. And after putting the third suture, you can see that the pupil is reasonably circular, so you can remove the viscoelastic. And once you remove the viscoelastic, that's the end of the procedure. And this way you can see that the IOL is right in center. There is no area of pseudophakic zone and aphakic zone. This zone has been completely covered by doing the pupilloplasty. So this was something that I wanted to discuss with you regarding as far as the cataract surgery is concerned. I would definitely like to have comments from you and questions and your inputs. We'll move on to the next section, that is cornea, and we'll cover up my part that I'll be covering. So I'll be covering the surface and stromal corneal opacities, how to handle surface and stromal opacities. Now, if you have a corneal opacity which is located only up to, say, around 60, 70, 80 microns, then in that case you can manage with PTK. Up to 100 microns you can manage with PTK, phototherapeutic keratectomy with excimer laser. If it's very superficial, even you can manage with regularize by doing alcohol delamination, and by use of a diamond burr you can smoothen the surface. But if it's up to 100 microns, you can debride the epithelium, which is about 50 to 60 microns, and ablate for about 40 microns. Once you are ablating, put mitomycin C 0.02% for 45 seconds. If the opacity is involving deeper down, up to 200 or 250 microns, then in that case, you can do a sutureless superficial anterior laminar keratoplasty. If the opacity is deeper down up to say 300 microns, then you can do a automated laminar keratoplasty or a manual laminar keratoplasty. And if it is involving the whole of stroma, then you can do a deep anterior laminar keratoplasty. So as I said, superficial corneal opacity, phototherapeutic keratectomy is the best. If it's up to 100 microns, you debride the epithelium, and once you have debrided the epithelium, you put excimer laser onto the surface, and then put bandage contact lens. You do excimer laser, wash it off, then dry, put mitomycin C, and then put bandage contact lens. Now, many cases of band-shaped keratopathy you can clear up with the help of PTK. Like you can see, this is the pre-op picture, this is the post-op picture, this is the pre-op picture, this is the post-op picture. Case of Rees-Buckler dystrophy, the pre-op picture, post-PTK, you can see it has cleared up significantly. A case of a pterygium, which is involving the visual axis. In that case, you do the pterygium surgery first. See, this is the pre-op picture. So you do the pterygium surgery, the appearance will be something like this. And then after this, you do a PTK, and then it will clear up completely. So any pterygium which is involving the center of the cornea, involving the visual axis, even if after removal of pterygium you can have some degree of haze or some degree of superficial opacity. That can be, if it is very superficial, you can still use a diamond burr to smoothen it up, but in large majority you have to do a phototherapeutic keratectomy. But if the opacity is a little deeper down, as I said, up to say 200 microns, like something like granular dystrophy or ocular surface disorder, in such a case, sutureless superficial anterior laminar keratoplasty is done. Now, how this concept of sutureless anterior laminar keratoplasty is done, I'll just show this video first. I'm creating a donor lenticule first with the help of a microkeratome. So this is the donor lenticule. This is a case of a Salzmann nodular degeneration, tracheomatous keratopathy. So manual, first debridement of the epithelium should be done, and then if there are nodules on the surface, you should remove the nodules manually, because if you don't remove the nodules manually, when you cut with the microkeratome, it will be irregular. And after cutting with the microkeratome, you see how clear it has become. Now there is cataract as well. So you can go ahead and do the cataract surgery, place the IOL in the bag, and then place the tissue, donor lenticule, onto the surface. And then you dry the edges, and once you have dried it completely, so drying the edges will draw the fluid from behind the cap, and then you put fibrin glue onto the surface, and then put bandage contact lens. Now this concept of sutureless anterior laminar keratoplasty came from the free cap of LASIK. See, if you do LASIK and there is a free cap, and if it's of, say, the intended size of 8 millimeters, then what will you do? You will just remove the cap, do the ablation, replace the flap, align it, dry the edges, put fibrin glue, put a bandage contact lens, and that will take care. So then people started thinking that if we have a superficial corneal opacity involving, say, up to 200 microns, we can do the same. And we can just cut the remove the superficial opacity by creating a superficial flap, and then put a similar thickness of donor lenticule, and that will take care of this case. And you can see here, this is the case of a granular dystrophy preoperative. See how many opacities are there. Now, earlier, before we started doing SALC, we used to do PTK in these cases. But with PTK, what used to happen that we cannot ablate too much. If we ablate too much, it will cause haze. So we used to ablate about 50 microns, 60 microns after debriding the epithelium and put mitomycin C. Still, sometimes we used to get some degree of haze in the stroma. But with SALC, you can see here how clear it has become. Because this is a pathology which involves the superficial stroma, and if you remove the whole pathology, then it clears up completely. Now, with femtosecond laser, the advantage is that you can be totally precise. The cut of the donor lenticule as well as the host tissue is very precise. Now, I'll just show you a case of a healed keratitis wherein femtosecond laser is being used to cut at a level of 200 microns. So if the scar is not dense, femtosecond laser can penetrate and it can do a cut. And we do it in a keratoplasty module. This is a vascularized opacity, so that's why there is bleeding. And then you just separate the cap, remove it, separate it completely, lift it up. And then once you have completely separated, you can place it back in its position and take the patient from the excimer laser, from the femtosecond laser OT to the routine OT, wherein you can just remove this cap. So you can see how badly opacified this is, but after removal of the cap, it clears up quite significantly. So as you can see, it clears up completely. The advantage of FALC is that when we used to do SALC with the microkeratome, there was some risk of epithelial ingrowth. But with FALC, the edge is vertical. So when you have a vertical edge-to-edge apposition, the risk of epithelial ingrowth is not there. And if there is some haze still present, you can smoothen it. Some irregularity can be smoothened with the help of a diamond burr. And this is what is being done. And once the diamond burr has cleared it up, once it is done, you place the donor lenticule of the same thickness. And once the donor lenticule is there, you can dry the edges, put fibrin glue at the edge, and then place bandage contact lens. And this is how it looks like. You can see the edge-to-edge apposition is very good if you do a femtosecond-assisted sutureless anterior laminar keratoplasty. And it works very well. It clears up the cornea significantly. But if it's a deeper opacity, you can do a manual dissection, do a manual LK, or you can do an automated LK. Now, the automated LK has the advantage that you have a smooth interface. The interface is very smooth, and you can go ahead and have a good quality of vision if you do an ALTK. But with a manual dissection, sometimes the interface is slightly irregular. It's not as smooth as when you cut with a microkeratome. So that's the advantage of microkeratome. Now, if the opacity is involving the whole of stroma, something like a corneal macular dystrophy, which is involving total stroma, or a keratoconus, in such a case, you do a deep anterior laminar keratoplasty. So for a deep anterior laminar keratoplasty, first we do manual trephination to a partial thickness depth, then we inject air through a needle in the predesmatic space. And once we have created a bubble in the predesmatic space, we separate the whole of stroma. This is the brave slash that it is called. So this means that as you make a nick and you reach the predesmatic stage, what happens is that the air escapes. So then you inject viscoelastic, high viscosity viscoelastic, so that the desmase falls again. I'll just show you how it happens in a microscope integrated OCT, and then once it has been done, we can remove the stromal tissue from all sides, take a donor lenticule, remove the desmase and endothelium, and then place it back in position and put sutures. Now, this is a case which I'll be showing to you, a case of a macular dystrophy. So, in a macular dystrophy, what I do a partial trephination and remove a little bit of stromal tissue and then inject air. So, after removing a little bit of, a layer of stromal tissue, these days what I do, I create a channel with the needle, create the you can see it's a nice type 1 bubble that has been formed. And if you inject a small air bubble in the anterior chamber, as you can see, there's an air bubble. Brave slash, the disk space went up. So that is how it is. And down. The disk space again has come down. Here we have this viscoelastic between the stroma and the disk space membrane. So you don't damage the disk space membrane by. And you can see here a bubble which is in the anterior chamber because the disk space is pushing it. Done. Then a similar size of donor lenticule is placed in position, and that is the end of the procedure. I'll just move it fast. Sometimes in a case of a healed hydrops, you have to do a layer by layer dissection. Why? Because if you do a big bubble DALC in such a case, it can open up the scar. It can open up the scar of the hydrops. So you do layer by layer dissection. And if you are doing layer by layer dissection, microscope integrated OCT helps a lot because that gives you an idea at what level you are working and how much of stroma is still left, whether there is any irregularity in the stroma on the two sides. That is also important. So as you can see here, if the stroma is more on this side, I will further dissect and remove it. Here there is a ridge that is present, so that can be removed with the help of simple Vanna scissors. And then once you get a smooth bed, you place a donor lenticule. So anterior lamellar keratoplasty is dependent on the type of opacity, the extent of opacity, the depth of opacity that you have. But if you have you have to do an endothelial keratoplasty, then I think routine endothelial keratoplasty I can show later, but I'll be just showing a complicated scenario of endothelial keratoplasty, that is in aphakia. Now, many times you do cataract surgery and there's endothelial damage. You can't put the lens. There is a PC tear. And in that case, then finally you refer the patient to a cornea person. So what are the issues in aphakia? There is one issue is related to refractive correction because you have not put the IOL. Second is that when you do an endothelial keratoplasty, there is suboptimal tamponade because air has a tendency to go back. And the third is risk of lenticule displacement. So in such cases, it is better to put a lens and then place a dissect lenticule. So you can do it with an anterior chamber IOL if the anterior chamber is deep. If the AC is deep and the IOL has been placed in position and the pupil is circular, you can just go ahead and place a dissect lenticule in an eye with anterior chamber IOL as well. And by tapping it, this is a thin lenticule, so by tapping you can stretch it, and that completes the procedure. And this is how it looks like. But if you have a condition wherein if chamber is not very deep and it's aphakic, then in that case you would like to do scleral fixation of IOL. Now, scleral fixation of IOL can be done by suture technique, as I mentioned earlier, with the by suture technique and also intrascleral haptic fixation. But as I mentioned earlier, pseudophacogenesis is much more in suture technique, and when you do an intrascleral haptic fixation, as you can see here in the ubium, the IOL is absolutely rock solid and there is hardly any movement. So intrascleral haptic fixation technique is a preferred technique in aphakia. And for an ultra-thin dissect, you first, on a microkeratome, you mount the donor tissue, then cut the anterior lamella, and then create the donor lenticule. And then this is the case of pseudophakia with a tilted AC IOL touching the endothelium, causing endothelial decompensation. So we are planning to remove this AC IOL and do an intrascleral haptic fixation of IOL. So the sclera is marked at 1.5 and 3 millimeter positions, and then you create a lamellar flap, and you debride the epithelium to have a better visibility, and then you do endothelial scoring. You place AC maintainer, and then you do scoring, and then after doing the scoring, the AC IOL is removed, the tilted IOL is removed, and then a multi-piece IOL is being introduced. The tip of the haptic is held with the lens fixing forceps, and it is exteriorized on one side, and then it is exteriorized onto the other side as well. And then the haptics are tucked into the scleral groove made adjacent to the flap, and a fibrin glue is placed, and this is how it is done. And then you place the donor lenticule in position in the anterior chamber and put air bubble. So this is how it has been done. A donor lenticular on a Busen glide has been placed, and now it will be placed into the anterior chamber. Air bubble is injected, and this is the end. So we published this study in the Journal of Cataract and Refractive Surgery, and then we found out that there are many cases wherein this was published in 2012. We found out that in many cases we require anterior chamber reconstruction, and the eye becomes hypotenuse. And in such cases, even if the lenticule is attached on the table, sometimes it detaches. So we thought that can we do it as a sequential procedure? Like first, you do the anterior chamber repair, you do iris reconstruction, do SFIOL, and then do ultra-thin DSEK. And this is what we did. I'll just move on. This is what we did. We did a study comparing single step versus two-step, and this was published in the year 2021 in JCRS. We found out that the sequential approach of doing ultra-thin DSEK following intrascleral haptic fixation after, say, a gap of 2 or 3 months provides much better result in these cases. And the last thing that I would like to mention here is that, as I was telling, that all these eyes are hypotenuse. So many times you inject air, even if there is an IOL, SFIOL has been done, because of the hypotenuse eye, vitrectomized hypotenuse eyes, what happens that there's a tendency of air to go posteriorly. There's a tendency of air to push the iris rather than push the donor lenticule. So what I have done, I've done a study, and we have just now sent our series, wherein I inject with the 30 gauge needle, I inject fluid from the pars plana after injecting air. And as you inject fluid in pars plana, and you check whether the globe has become firm or not. And once the globe becomes firm, you see that the air comes up anteriorly nicely and causes a nice tamponade and maintains that tamponade. In all the 13 eyes which we have sent for publication, the eye did not require a rebubbling. These are high-risk cases wherein rebubbling may be required in a large majority of cases. So this is the post-op picture of one of the cases. I will now request Professor Namrata Sharma to start with the posterior polar cataract and cataract surgery in eyes with corneal opacity and corneal disorders. And then she will talk about the endothelial keratoplasty.
Mic is on. Yeah. Thank you, Dr. Rajesh, and thank you for this great concept and this session. I am going to be talking to you about phacoemulsification in corneal haze, and I'll begin with this case, a non-eyed patient, one eye lost due to keratoplasty in the following corneal transplantation. And so the patient didn't want a corneal transplantation procedure in this eye, and there was a hard cataract. this is the only seeing eye, so we decided to do a cataract surgery alone. Now, it can be quite challenging. The first and foremost, you have to plan your incision. So you have to plan it in such a manner that at least this half of the cornea is clear. So that at least one half should be there where you should be able to do the working. This is a hard cataract, so the trypan blue staining has been done of the anterior capsule. And just as you go underneath that haze, you have to come out in one stroke. Don't leave the edge of the rexes underneath that haze, because if you do it, then it will become very difficult for you to relocate it. And sometimes you have to pull the globe like this a little bit to see the edge of the rexes from there. Now, this patient also had a optical iodectomy, and so that is why an eccentric rexus is being done here, because this is the area from the patient will also see post-operatively. And you do an eccentric crater as well, because that is the area where you can see. Always, always put your retro illumination on, because once you put your retro illumination on, against that red glow, you can actually see the grayish or the whitish fragments better. And so just notice that this is phaco in situ. That means you chop and you eat, you chop and you eat. The advantage of that is that the red glow is going to get better and better, and so your contrast is going to get better. Sometimes you may have to also lollipop these small fragments from underneath that haze into your irrigation aspiration probe, so that you get the whole of the cortex out. And then looking at the edge of the rexus, a foldable intraocular lens has been now implanted, which is in the bag. So you don't expect the patient is going to get 6 by 6 or 20 by 20, but even if it is 2 lines less, it is fine, because the patient is one-eyed and has become ambulatory without having to do a corneal transplantation. Now here, this concept is essentially this, that when you have a central corneal haze like this, then you do peripheral chops. And they may be incomplete, it doesn't matter. The advantage is that the whole of the nucleus is not going to spring back into your capsulorhexis bag, because you've already kind of paralyzed it by these peripheral chops. And so as a result of which, it becomes easier to do phacoemulsification. In all cases of haze, whenever it gets blurry, just put a blob of viscoelastic there, so that for that split of a second, it is going to become a little clear, and it will at least allow you to initiate the step. So this is essentially to show that you do peripheral chops, so the nucleus becomes less springy, and then you can do you can carousel out the peripheral part of the nuclear fragments, and subsequently do nuclear emulsification and foldable intraocular lens implantation, which is done in the bag. Now this is a black and a white cornea because of the haze, and black because it is tattooed. And you can see that there is synechia here, and the synechiolisis is done, and subsequently because the pupil is small, so you have to expand your area of visualization, so nylon hooks are placed, and then again use the capsulorhexis forceps, because it gives you a better control. Don't lose the edge of the rexus underneath the haze, because if you lose it, it becomes very difficult to pick it up. Of course, intraop OCT microscope does help you to pick up the edge of the rexus, but if you don't have it, then it becomes difficult to pick it up. And then do hydromaneuvers, which are quite copious and vigorous, because that kind of causes disassembly of the nuclear fragments as well as the epinucleus. Again, follow the same principle, put the retroillumination on, and even if you keep your phaco probe in the center, it doesn't matter. If you've done a good hydrodissection, everything will come in the center. And then subsequently, irrigation aspiration of the cortical fragments is done, and notice how clear it has become. And then foldable intraocular lens implantation will improve the optics even more, and the case is completed. Always remember to do a little bit of sphincterotomy in these cases, because you may require it, because the post-op period, when the pupil comes down, then you don't know from wherein the patient is looking. So once you do this sphincterotomy, put some amount of pilocarpine. That's kind of a test to let you know from wherein the patient is actually seeing, or how much the patient is going to see in the post-operative period. Now, this is a high-risk case for corneal transplantation. So again, a cataract surgery is being planned. Temporal incision, because this part is clear. Nylon hooks, because you have to expand your area of visualization. And then the endo-illuminator is inside the anterior chamber, so that you can do the chopping and nuclear emulsification. Now the endo-illuminator is outside, so that it allows you to do the foldable intraocular lens implantation in the bag. and subsequently the nylon hooks are removed. So from counting fingers, patient improves to 612, again allows him to be ambulatory. This is yet another case where the visual acuity is 612. These are cases of Stevens-Johnson syndrome which are high risk for corneal transplantation, and so it is best to leave them with cataract surgery alone because you don't want to melt after a corneal transplantation in these cases. Now, this is another case, a post-penetrating keratoplasty case with cataract, with haze, and again, small pupil. So nylon hooks is being used to expand the area of visualization, blob of viscoelastic so that it gets clear, and then subsequently the trypan blue staining of the anterior capsule is done. The nuclear emulsification is being done. Endo-illuminator is being used here, and see, because of the internal reflection from inside, you can actually see much better, at least the nuclear fragments, so as to allow you to do the nuclear emulsification, irrigation, aspiration, and then in the bag IOL implantation, subsequent to which the nylon hooks are removed. Now, even flax helps in cases of corneal haze, and the advantage of this is that it kind of gives you fill in the blanks. So it will not do a complete rhexis, but that doesn't matter. You can pull it out from the area which is cut to the area which is non-cut, and at least this part of it is already cut. Likewise, it is not going to do the chops underneath the haze, but that doesn't matter. You can at least take the advantage of the other chops that have been done, and that will reduce your phaco energy, especially in these cases where there is corneal opacity. Now, this was a case in which we were planning to do a deep anterior lamellar keratoplasty. So a partial thickness triffonation was done. The anterior lamellae were removed, and then subsequently the cataract surgery was initiated. Again, capsulorhexis was done after staining it with the trypan blue dye. Subsequently, nuclear emulsification was undertaken, and the foldable intraocular lens was implanted. And after implanting the lens, again, notice that it's blurry, so put viscoelastic. You can see where the margin of the capsule bag is, and then subsequently the last bit of the stroma is also removed. Full thickness donor cornea is taken, and with 10-0 monofilament nylon sutures, the case is completed. So the patient has a visual acuity of 20/40 or 6/12. Again, for a patient who's one-eyed, this is a good visual acuity and allows the patient to be ambulatory. This case was referred to us for corneal transplantation, but we thought we would do a dissect triple. So first rhexis, that is the epithelio-rhexis, is being done in this case. And then second rhexis, that is the desmetorrhexis, because the Descemet's membrane is diseased, is being removed. Again, you can do it with after staining it with the trypan blue dye. And then subsequently third rhexis, which is the anterior capsulorhexis, is being done after staining it with the trypan blue dye. And then consequently phacoemulsification is being done. Now, do not have a posterior capsular tear. In such cases, it doesn't matter you are anterior, because anyway you're going to replace the endothelium and the stroma. This is followed by the foldable intraocular lens implantation. The stromal lenticule with the Descemet's membrane and endothelium, which is taken, pulled intracamerally inside, the air bubble which is instilled, and then subsequently the graft is centered. Now, over a period of time, it clears up, so this patient has a visual acuity of 6/9, and we didn't have to do a full thickness corneal transplantation in this case. And this was a sutureless transplant, and this is now more than 5 years the follow-up case. Now, in cases where you have cataract along with the Fuchs dystrophy, you have to do a DMAC triple, and in this case, the Descemet's membrane is stained with the trypan blue dye, and this is being pulled with the help of the McPherson forceps. And once you do that, then partially triffonate about 8 millimeters, and then very gently peel off that Descemet's membrane to get the Descemet's membrane scroll. Subsequently, the cataract surgery is done after staining the anterior capsule with the trypan blue dye, the nuclear emulsification, irrigation, aspiration, and then the desmetorrhexis is being done, subsequent to which the DMAC would be done. So this is the physiological Descemet membrane roll which is taken in the cartridge, and then you just inject it and subsequently unfold it into the anterior chamber. Now, what side is up? You have to basically get a biceps curl upwards configuration, and this can be seen on the intraop OCT microscope. Once you get that biceps curl upwards, this is an inverted graft. So you have to put some fluid so that it becomes, comes into the correct orientation, so that the endothelium side is actually looking down and it is facing the stroma, subsequent to which the air bubble is instilled. Now this is the case in the postoperative day 1, and subsequently this is the case in the postoperative month 1. So even your fellow ophthalmologist cannot make out that there was ever a DMEC graft done. Sometimes even I get confused and I have to make the patient, sit again on the slit lamp to see that there is an edge of the graft. It is so physiological. So this is what we published, phacoemulsification with coexistent corneal opacities. The algorithm is this: cataract surgery with corneal opacity. If it is small and central, then phaco alone. Small central corneal opacity covering the visual axis, then optical iridectomy. If it is corneal opacity involving the superficial cornea, then PTK with phaco. Cataract surgery with corneal opacity, if it is central, depending upon where it is. If it is in the up to 1/3 of the corneal depth, then you can do a SALC triple. 2/3, you can do ALTK triple. More, just now I showed you a DALC triple, and if it involves the endothelium, then DSEC or DMEC triple, and if it involves all the layers, then PKP triple can be done. So these are the tricks to summarize. Incision placement is crucial so that your clear area or clear zone is known. Microscope should always be in retroillumination. Aids are required like nylon hooks, optical iridectomy, trap and blue dye, endo illuminator, HPMC on the surface, dispersive OVD, BSS plus preferably. You may have to do eccentric rater, peripheral chops. Phaco in C2 is required. That means you chop, you eat, and low fluidic parameters, and you have to make the patient understand that ambulatory visual acuity is the goal that you are looking at, and not an eagle's eye vision. So thank you very much for your kind attention.
Thank you, ma'am. It was really a complete thing about phacoemulsification in corneal opacity and corneal disorders.
We have a talk by by an international speaker here.
Okay.
You can take this, then after that we can continue.
Okay.
So, one question. Ma'am, what kind of IOL power adjustment you do in DMEC triple?
IOL power.
Yeah.
So I tend to take, because it's going to cause about 0.05 diopters of hyperopia. So I take more or less the emetropic power. I don't factor in for that, which I would for a DSEC.
DSEC, yeah, definitely we do 1 or 1.5. But no change in?
No, I think in DMEC.
Nothing for
change.
So the next talk is going to be by our international guest speaker. May I please invite him?
Dear colleagues, thank you very much for giving me an opportunity to give my presentation, which should have been 2 days ago. Unfortunately, I misread the email by Professor Sharma, and we had some travel issues. And I speak about a much simpler topic than what was just presented. I speak about the transition of trifocal IOLs to EDOF and reasons why we're doing this. I have no financial interests in the lenses mentioned. However, I have to declare that I do have an emotional conflict of interest, because I have been working with Care Group for many years, and we have met many times, even in social circumstances, and I can be blessed and honored to call myself a friend of the Care Group management, so I am involved. So trifocal IOLs that we have been using in the past have excellent far, intermediate, and near uncorrected visual acuity, and they have a reliable, proven performance. However, essentially there comes a reduction in contrast sensitivity, some photic phenomena that we're all aware of, and of course it's depending on the pupil size, which is a problem in the aging population, especially in Europe. Patient satisfaction is usually very good. However, the unwanted effects are very relevant within especially our European population, because a significant proportion of these cataract patients are actively driving. And night driving especially is very important, because in the wintertime we are so far north that from 3:30 in the afternoon till 8:30 in the morning it is pitch dark. EDOF IOLs provide continuous restoration of visual acuity from intermediate to far with less photic phenomena, and they are very effective in combination with a minimal monovision. Of course, the uncorrected near vision will not reach the level of a trifocal IOL. But this makes special sense in the educated and active driving population, because intermediate vision is very important for PCUs, and near vision becomes less and less important because reading is usually done on high contrast devices. Actually, reading newspaper, small print is getting less and less in Europe. And less glare and halos is essential for night driving. So I just report a small group of patients, 31 patients, who had a bilateral phacoemulsification, 1 center, 2 surgeons, and we implanted the magnificent EDOF IOLs. And very important, the refractive target was emetropia for the dominant eye and minimal myopia in the non-dominant eye. Inclusion criteria are hyperop or mildly myopic eyes, not very myopic eyes. And of course, there should be no associated ocular pathology like AMD and glaucoma. Corneal astigmatism should be low. And of course, patients have to be advised prior to surgery that these EDOF IOLs provide good far and the intermediate vision, but they have to expect to still use reading glasses for very small print. The refractive results, as I mentioned, are very important. You see here in blue the dominant eye, which is mostly emetropic, and the non-dominant eye, who should be a little bit more in the myopic range. In one eye, actually, we had to exchange the IOL 2 weeks after the first surgery because of a biometry glitch. It's very important that you achieve the correct refractive target, but all other surgeries were uneventful. Our clinic, although I lecture at Zurich University, we are a private clinic. You know, we're not an academic center, so we are not doing standardized measurements for intermediate and near visual acuity, but we use a questionnaire regarding patient satisfaction and spectacle use, which is at the end of the day what counts for patients. So one question is, how do you rate the visual function after surgery overall? And all the patients responded good or excellent. And now the important questions are, do you use spectacles for distance vision? Do you use spectacle vision for intermediate? This is computer. Do you use spectacles for reading? And do you experience visual phenomena during driving? And the important numbers are highlighted in green. It's quite amazing that about 60%, despite we are not promising them to read spectacle-free, about 60% answer that they use rarely or never spectacles even for reading, and 80% do not experience any visual phenomena during night driving, which is amazing in a population in the winter where dry eye is also a very important topic during driving. So in summary, the magnificent EDOF IOL offer an excellent alternative to trifocal IOLs, and because the unwanted optical effects are largely avoided, this is a good trade-off for an increase in spectacle use for really near visual tasks. And this compromise makes special sense in a digital and driving cataract population, which is definitely also increasing in this country. And the limitation of my presentation is this is only a small number. It is uncontrolled data. I understand we should, compare to trifocals really. And I have a little bit an emotional conflict because I'm a friend of Care Group. Thank you very much.
So much. Thank you so much for that nice talk. how many, what is the follow-up that you have in these cases?
So we do this, well, you know, actually we call patients back for follow-up after 1 year,
Okay.
but this data is after 3 months.
3 months, okay.
Yes.
Okay. Thank you so much. Thank you. Rajesh, you
Any-
would want to ask any question?
Yeah.
Anybody?
Question or any comment from anyone? Well, EDOF lenses are, you know, various designs and various companies are coming up with EDOF lenses, which are advanced monofocal ones. What do you think is the superiority of, you know, these advanced monofocals over the earlier generation EDOF when, you know, the ones that we had earlier like Symphony wherein we had rings and all those. So, do you think these advanced monofocals have slight edge over these because of lack of any photic phenomenon, and also if bilaterally implanted will have a decent intermediate vision?
Well, I think, you know, like in life, nothing comes free, even in cataract surgery. So if you want a real tree-far quality, you pay with a loss of quality. And these rings with the sharp edges in a real trifocal lens is calling for this phenomenon. So by avoiding this, by having a continuous optic, this is avoided. And the trade-off is to give in the near vision a little bit. Of course, there are various technologies on how to do this on the optic with the spherical aberration and so on. Every lens is an individual. And of course, one also has to look at the cornea of the patients, whether there is already a spherical aberration. But I think that's really, really a good compromise, these EDOF lenses.
Okay.
Thank you.
Thank you.
I just have one more question. If a patient has got a monofocal IOL in one eye, in the fellow eye, would you put a EDOF? Or you tend to do bilateral EDOFs?
Well, I think you should always do it bilateral, if you can, if you have a chance. If a patient has a monofocal IOL in one eye, I would rather give him the advice to go for a real monovision rather than an EDOF in one eye only. But anything is possible if you speak to the patient. But the real benefit of the EDOF is if you implant it bilaterally.
And there's one common question that is frequently asked by many people to people who present on EDOF or trifocals or multifocals, that given a choice, if you have to undergo cataract surgery, what will be your IOL of choice?
Well, it's a very difficult question because I'm myop. I'm a happy myop. No, I'm not an emmetrop. I am actually currently trying multifocal contact lenses to see how it is before I get cataract. But being a myop, I probably go for myopia. And spectacle freedom is not a goal for me personally, so I'll go probably for -2.5.
Okay, so it depends on what the patient is aiming for.
Yes.
Absolutely.
So, thank you so much.